Well, thanks everyone. As Whitney said, I am a gynecologic oncologist, so I treat these cancers, but I also take care of patients with genetic syndromes, including Lynch syndromes and other syndromes that put people at increased risk. I wanted to say I have no disclosures related to what we're going to talk about, and then we're going to quickly talk about these two gynecologic cancers in general, just to give you a little bit more information about ovarian and endometrial cancer. There's a little bit of redundancy with what both Dr. Kanth and Catherine talked about, but I think it doesn't help when there's so much information to hear things a couple times, so I'll just quickly go over those risks, but try and focus on our surveillance strategies and our risk reducing strategies. So when we think about these cancers, they're actually very different cancers. They get lumped together because they're related anatomically, and obviously they're unique to women. But ovarian cancer is very rare in the population. The general population risk is 1%. We do not have a good screening test for this. So obviously people in the general population get pap smears for cervical cancer, they get colonoscopies, they get mammograms, but no one gets screened for ovarian cancer, and that's because we've never really found an effective screening test. The symptoms for ovarian cancer are really subtle. This has been touched on, but things like bloating, pelvic pain, change in appetite, nausea, things that people are going to have all the times in their life and aren't necessarily going to think is related to a cancer. And because of this, because the symptoms are so subtle, it's often diagnosed at a late stage, and it's often incurable when diagnosed at a late stage. Endometrial cancer is a really different cancer. The general population risk is still low, 3 to 4%. And also we don't have a screening test for it. We do endometrial biopsies, which we'll talk about, which are very good at finding endometrial cancer, but we don't do them to the general population, and not always even in Lynch syndrome. I'll talk about that. Because usually people develop symptoms when they have endometrial cancer, the most common being postmenopausal bleeding, or bleeding after someone has gone through menopause and should not be having periods, or abnormal bleeding, irregular periods, frequent periods, heavier periods, bleeding between periods. And they present and then get diagnosed. And so endometrial cancer is often diagnosed early stage and is curable. This is my picture, and I hope you can see my thing. Just to remind everyone of the parts we're talking about. So this is the uterus. This is the endometrial cavity, which here is shown kind of open. And then you have two fallopian tubes and ovaries. So when we think about endometrial cancer, a minority of endometrial cancers are Lynch related. As has been discussed, the majority are sporadic. But the average age of diagnosis is younger than when we see it in the general population. And your cumulative risk through age 80 can be as high as 50%. Again, this is similar to the mutation data that Catherine showed. This is just different populations looked at different studies. And so we see the mutations here along the bottom, and then we see the percentage cancer risk along the side. And it is variable for these mutations, but you see in general a higher risk here and a lower risk, but still a significant risk for the PMS2 patients. When we go to ovarian cancer, so here I've zoomed in on the fallopian tube and the ovary, because when we talk about ovarian cancer, we actually talk about ovarian and fallopian tube cancer. This is more known in our BRCA patients, but it may also be true for our Lynch syndrome patients, that some of what we think is ovary cancer is actually starting in the fallopian tube. They are treated the same way, they behave the same way, and so we lump together fallopian tube and ovary cancer. Again, the majority of ovary cancer is not caused by Lynch syndrome, but we see patients with Lynch syndrome diagnosed at a younger age. And then your cumulative risk through age 80 can be as high as 20%. And it is a very mutation dependent risk, mostly because, and the risks are a little bit higher now than these studies. The NCCN data that Catherine showed you earlier is a little bit more updated. But not a lot of increased risk seen in the PMS2 patients, as high as 3% in some studies. So surveillance strategies. So when we think about surveillance, the goal of surveillance is kind of two things. One would be to catch something before it becomes a cancer, and the other would be to get it at an early stage so that you could cure it or have to do less treatment than if you got it at a later stage. And when we think about surveillance strategies for these two cancers, you really have to think about them differently. So people have talked about doing endometrial biopsies. This is a picture of an endometrial biopsy where it starts just like a normal pelvic exam, like a pap smear, but instead of a pap smear, we actually put a small straw up into the uterus to do a biopsy. Sometimes these can also be done in the operating room by scraping out the lining of the uterus if it's not able to be done in the office. And we've asked, should we do that every year or every couple years to try and detect endometrial cancer? We can't necessarily detect precancers doing this for our Lynch syndrome patients. And so we really would be detecting cancer. And what we've shown is that we haven't been able to really save lives from doing that, because usually, even if there was a cancer, people would have symptoms very soon. They would have abnormal bleeding, and we would do the biopsy, then diagnose the cancer, and the treatment or the treatment and the outcomes would be the same. For ovary cancer, I will say though, we do offer this in select cases, especially patients who really want to keep their uterus in order to keep having children, maybe have some abnormal bleeding at baseline that is hard to interpret, and then have a family history of young cancers that makes us concerned that we don't want to miss a young endometrial cancer. So it's not necessarily a routine recommendation, but it is something we consider. For ovaries, people have talked about doing ultrasounds of the ovary and then also doing CA-125 levels. A CA-125 level is a blood test. Oh, sorry. That can detect a protein level in the blood that is sometimes elevated in ovary cancer. And we really see, again, mixed evidence because there are lots of false negative and false positive tests. False negative means we look and everything looks normal, and then people develop an ovary cancer before we look again. Or false positive means that a CA-125 or an ultrasound looks at normal, we go in, we put a woman through surgery, maybe younger than she needed, and there was not a cancer. And so again, we've never had high quality evidence to say that everyone with Lynch syndrome should go through these. But we do talk about it on an individual level when we're worried about family history and when people really want these organs retained for fertility or childbearing purposes. What I do recommend is an annual examination with a gynecologist. This is a low-risk intervention, and at that visit, usually your gynecologist, especially if they know you have Lynch syndrome, should be asking you questions about abnormal bleeding, those vague symptoms we talked about, and then deciding if it would make sense to do any of these tests. But it's a personalized approach that takes into account family history and mutation. The more sort of strongly recommended consideration is to consider risk-reducing surgery. So obviously, unlike the cancers that everyone else has talked about, the uterus does not provide people with long-term benefits. And so we can remove the uterus, and the hysterectomy is a very common procedure. Again, this is a personalized approach where we want to consider doing it prior to the ages that we see people developing these cancers. But it has to take into effect family planning, childbearing, family history of cancers. The standard surgery to consider reducing your risk of getting an endometrial cancer is what's called a total hysterectomy. That just means remove the uterus and the cervix. And then we often now include self-injectomy with that, removal of the fallopian tubes. Without a uterus, you do not need fallopian tubes. And because some cancers may start there, we now routinely remove them. This is very successful at reducing people's risk of endometrial cancer to 0%, as long as there's no cancer at the time of the surgery. The next decision becomes about removal of the ovaries. Again, because of the low rates, we have said, and our national body, NCCN, has said that this is hard to routinely recommend for women with PMS2, but we can still consider it. Obviously, removal of the ovaries does come with downsides. Your ovaries provide you hormonal benefits. The one thing people think of the most is symptoms of menopause, but obviously a lot of other benefits to having ovaries too. The good news is most Lynch syndrome patients are candidates for estrogen replacement after their ovaries are removed, and that can manage a lot of the symptoms of menopause as well as the risks of menopause for overall health. Unfortunately, we wish we could say removing the ovaries takes your risk of ever getting an ovary cancer completely away, but we do see cancers called primary peritoneal cancers. They're very rare, but they act like ovary cancers, and we can see them even after ovaries have been removed, but we've taken the risk down significantly. Right now, if women are planning oophorectomy, we often recommend it at the time of their hysterectomy, but I'll talk about that a little bit more in a minute. So this is just a nice graph that looks at patients with Lynch syndrome who got hysterectomy and who did not, and were followed over time, and we see what we would expect, which is that over time, women with Lynch syndrome developed endometrial cancer. That's what we see here. But the women who had the hysterectomy did not. 0 endometrial cancers were seen. A few more considerations with risk-reducing surgery. Occasionally, patients are undergoing surgery for their colon cancers and are known to have Lynch syndrome. And sometimes we do consider doing their hysterectomy at the same time. It's not always, but it is an option. And up at Huntsman, we have done that for several patients. There's sometimes a preoperative workup. So as I said, I'm a gynecologic oncologist and can take care of Lynch syndrome, but can also take care of cancer. If you're being seen by a gynecologist, they may want to rule out the chance that you have a cancer before doing your risk-reducing surgery, and so would consider some of these tests. The surgery can be done minimally invasively, and really that means a few different routes. When we think about hysterectomy alone, this actually most minimally invasively way to do a hysterectomy is just a vaginal hysterectomy, which doesn't involve any abdominal incisions. However, when we want to take the tubes and ovaries and really do a comprehensive removal of those, we often will recommend a laparoscopic hysterectomy or robotic assisted hysterectomy. And for those surgeries, women usually stay in the hospital 0 to 2 days and have a 2 to 6 week recovery. Occasionally, people do have to have what's called an open hysterectomy, where an incision is made to do the surgery. And that doesn't depend on Lynch syndrome. It actually depends on a lot of other situations. And that would be a longer time in the hospital and a longer recovery. After the surgery, we don't do any further risk reduction, but do recommend that women just have regular gynecologic care. And this is just some pictures showing different incisions. So this is an open surgery incision. These can be the locations for laparoscopic incisions, and on the far side for robotic assisted surgery incisions. I do mention for my patients who sometimes get surgery done other places that you just want to make sure your surgeon is familiar with doing a risk-reducing surgery. And these are the most important things, that they get pelvic washings, that they get back on the ovarian blood supply to remove the whole ovary, and that everything is completely sectioned and reviewed by the pathologist to rule out that there was a cancer at the time of the surgery. I'm going to briefly touch on chemo prevention, and I might again be overlapping with other people's talks. But we do know that something as simple as birth control pills or combined estrogen and progesterone in the form of pills, patches, rings, we have lots of different ways to do it, decreases endometrial and ovarian cancers in the general population by suppressing ovulation, by protecting the endometrium. We recommend that patients who are candidates for these medications consider taking them between childbearing while they're still in their childbearing years to try and decrease their risk of these cancers. And then we are thinking and talking more and more about a sort of delayed surgical approach where when women are done childbearing, we could remove their uterus, but we could let them keep their ovaries until a little bit later in life. There's not much data on this. There's a little bit of data in a BRCA population, which is a different genetic risk family population. And what it shows has not been cancer outcomes, so we don't know if it's as safe, but it shows really high quality of life actually in both groups, which is reassuring to us that whether women choose to get their ovaries out or not, they're reporting good control of their menopause symptoms and quality of life afterwards. And so thank you all for listening, and it is still Gynecologic Cancer Awareness Month, so happy Gynecologic Cancer Awareness Month.